Sounds good. Welcome, everybody. As Marie said, there is a lot to get through today. I think CMS has been dreaming up different ways to make our lives challenging. So we're going to jump right into it. I think we're going to jump right into it. Okay. So just standard disclaimer, right? Things change from CMS all the time. In fact, this morning they published 2 new HCPCS codes, but this is current as we can make it right now. All right, we're going to start with, and I guess I should also warn as we go, I may kind of jump over a couple of slides just due to time constraints. I wanted you to have all the information, but there's certain things in here that maybe 1 or 2 of you will care about, maybe nobody because it's new technology type stuff. So that will be in the presentation, but I'm not going to spend a lot of time on it as we go. All right, and this is one of those slides, right? I wanted you to be able to see what happened to the payment, but there's not a lot to say here. We're going to continue with the 2% reduction if you don't meet the quality reporting requirements, which are at the end of this presentation. The adjustment for sole community hospitals is going to continue, and the adjustment for those 11 cancer hospitals is going to continue. All right, we're continuing with the new wage index calculations, which started last year. They're continuing to cap any decreases at 5%. So your wage index would never go down more than 5%. This is kind of the only important one, and we're going to jump into this a little bit more later when we talk about the 340B drugs. But there was a little bit of a decrease in the conversion factor because CMS was having to account for changes in the 340B program. And the outlier payment did change by quite a bit, or the threshold. You can see it's up from $61.75 last year. It's now up to $86.25. So you have to meet a much higher standard before you qualify for outlier payments under the Outpatient Prospective Payment System. Other than that, no change to the way they're calculated. You're still going to get 50% of the amount that exceeded the cost threshold times 1.5 with a 1.75 multiplier on the APC payment. It's a little complicated. If anyone needs more detail on that, I can give it to you in the Q&A. All right, so now we're going to start with all of the stuff that changed for the comprehensive APCs. And fortunately, there's not too much. So quick reminder that the comprehensive APCs are what I like to call like the mini DRGs. So they are procedures which bundle in everything else that's done on that day, including other procedures, drug supplies. Those are typically bundled in anyway. So we have one new comprehensive APC being added. It's the level 2 urology. And again, I wanted you to see all of the codes that are included in that. So any of these things that are done, which, you know, cystourethropscopies are pretty common, hopefully not neonatal circumcisions in Medicare patients, but sometimes. So all of these procedures are now comprehensive, which means if this is done and you do any other service, it's basically going to be packaged into this procedure. They kind of finalized and emphasized a couple of things, which is that they're going to be continuing the current packaging exception for COVID-19 treatment through the end of the public health emergency. So we don't know exactly when that end is going to be right now, but for now, any of your COVID-19 treatments that are done with any comprehensive APC are still going to be paid separately. And there's a couple of conditions there, right? It has to be authorized to treat COVID-19, and it has to be authorized for use in the outpatient setting in order to be receive that separate payment. They also added in, this is kind of just a different way they're processing things, but I bet you it's going to impact several of you. So they have a new packaging exception for any drugs reported using that C-9399, which is the unspecified drug or biological. It's basically for the new drugs that kind of are so new they don't have their own HCPCS code yet. And they're going to be manually priced at 95% of the AWP. Now, that's not new. That was always supposed to be happening. But apparently, some of the MACs were having trouble with that, and that was not always happening the way it should have. So in order to make that happen, what they've done is made C-9399 is going to have a status indicator of A now. It's going to be manually priced, and that should make sure that you always get separate payment for that when it's appropriate. And of course, because it's in this section, it's also an exception to the comprehensive. So it should always get separate payment, whether it's done with a comprehensive APC or not. All right, we have a lot of updates to APC specific stuff. Again, I'm going to go a little bit quickly through this, but all of the information is there. So the way that I've organized this, basically, these are new technology groups. Basically, what I've done is to show you in green here if the payment is going up, in red if the payment's going down, and you can see what the payment was last year. Just again, if any of you do any of these, that way you can look through and see what your changes are going to be. So we have some changes, C-9770, which is for the administration of Luxturna. So that's for retinal dystrophy treatment. Payment on that is going up. Your PET studies for the myocardium, one went up and a couple of them are going down. All right, we have actually pretty good jump in reimbursement for the esketamine administration, which is for, it's a drug that's inhaled. It has to be inhaled under the supervision of a qualified health professional, and it's for treatment of resistant depression. So payment on that went up fairly decently. The payment for the neurostimulator system for treatment of sleep apnea went way up. That's because not a lot of places are doing that yet. So they're going to be really looking at claims for this next year. So if anybody's doing that or considering doing that, make sure that you've got that priced in accordance with your costs. And that will help with that one. All right, we have a lot of changes on the hernia repairs. If you guys want more detail on the actual coding changes, I'm going to hit this in the CPT updates, which is coming in a couple of weeks. So you could see our website for future webinars. What I'm just going to tell you right now is that the coding has really changed. It used to be based on the type of hernia, the approach, the age of the patient, whether or not it was recurrent, and whether it was reducible or incarcerated. So that part's still important. The reducible and incarcerated, the recurrence is still important, whether it's the first instance or whether it's recurrent. Now the size is important. Age is no longer important, and the location a little bit important, but it has different classifications now. So in order to price this, because these codes are very different, CMS is basically looking at the state of the hernia to be the differentiator. So let me explain what I mean about that. So if it's in this column, and you can see these are the reducible hernias, those are going to be reimbursed at a rate of $35.42 next year. And that's not specific to anybody. That's the national payment. So that is not exactly what your facility will receive, but that's national. If it's an incarcerated hernia, it's going to be reimbursed at that $52.12. And we have several of these now that are inpatient only. So if you have a really big hernia that is incarcerated, those are going to fall into the inpatient procedures, and you can't do those on an outpatient. And the peristomal hernias are inpatient only as well for next year. And then we do have removal of mesh or prosthesis at the time, and that's just packaged. Be sure to report it, but it's not going to receive separate reimbursement. All right, now again, we're gonna move through these fairly quickly, but these were some significant payment differences and other things. So if you do the ophthalmic insert, and I tried to help everybody as much as I could when it applied to a particular drug or brand or something like that, I'm trying to put that in so that you have that information as well. So if you insert Dextenza, that's going up very, very significantly, primarily because the drug, the Dextenza, is not getting pass-through payment next year. So the cost of the drug is being bundled into the procedure. Still charged for it, but no separate reimbursement. Artificial irises, we have a code for insertion without intraocular lens, with intraocular lens, and then an exchange. So right now, the insertion without is assigned to $54.91 and gets $2,000. These next two are currently assigned to $54.92 and get $4,000. Next year, all of these are going to a single APC, and they're all going to get $18,000. So again, quite an jump up in the reimbursement for that. New and unclassified blood products. They're changing just slightly the way that they're going to be dealing with blood products. So we're still going to use P9099, which is totally for an unclassified blood product. They just, CMS expects that this code is almost never going to be used anymore because they're going to start dealing with the blood a little bit differently in that when there's a new product on the market, they're going to very quickly assign a temporary HCPCS code, and they'll determine the cost of that by crosswalking to existing products until they have cost data. So as though we don't have enough code changes throughout the year, these are going to start popping up. Although I'm going to admit, I don't know how often new blood products come on the market, so I doubt this will flood anything. But expect to see new codes coming. The bone density tests, we have a few that are considered new and emerging technology that are described by T codes. So these three are bone mineral density studies using data from existing studies. So it's a software as a service, or a SaaS, where no actual study is being obtained at the moment, but the existing study is sent on to do some AI analyzation. Those are going to be a status indicator E1. CMS doesn't like this right now. They don't think that these meet the definition of payable bone mass measurement, but they did actually put in the final rule that they realize that a lot of people may not agree with that. And so they said, if you don't agree with that, please go through the established NCD process or National Coverage Determination process to request a reconsideration of their decision. So that kind of makes it sound like they're open to recognizing these, but at this particular moment, they don't see a need for these additional types of studies. The cardiac contractility modulation, which is that device that's inserted kind of sort of like a pacemaker, only it's for heart failure patients, and it basically makes the heart pump more efficiently to push the blood out. That procedure is being reassigned, and it got a pretty good jump there too, from 23,000 to 32,000. The Clarifix procedure, which basically uses cryotherapy or localized freezing. It inserts a cooling probe and it freezes a small inflamed area in the back of the nose. It's used to help to help treat chronic rhinitis. By freezing the tissue, you kind of relieve the inflammation and the pain. So that is being reassigned. And again, that's pretty darn close to doubled. So that's kind of nice. If you are doing that or considering doing that, the reimbursement is more in line at this point with the cost. Colonic lavage, which sounds just absolutely awful, but is used to reduce strictures by forcing a lot of water. That actually is kind of importantly being reassigned to a different status indicator. So that means if you do this procedure with any other procedure previously, or I guess currently in 2022, that's going to be bundled into any other procedure that you do at this moment. But next year it will be separately reimbursable, and it almost tripled in reimbursement. So kind of nice to know that they are listening in some cases where their reimbursement's too low. All right, COVID-19 vaccine administrations, and I'm going to try and talk you through this. This is one of those rules that it feels to me like they're purposely trying to complicate things. So they're going to continue the site-neutral payment. Right now, the site-neutral payment is $40, regardless of whether that's the first vaccine or the second or the third or whatever. They're changing it slightly. They're going to continue that site-neutral payment, but if the emergency use authorization is terminated this year, the payment rate for next year is going to be $31.14, and that is for all, first dose, second dose, third dose, whatever. If the emergency use authorization is not terminated this year, then the payment for next year is going to be $41.52. The explanation they gave for that is that they want to make sure that there's continued access to vaccines for the duration of the emergency use authorization. And you should also know that this $41.52 is probably going to change depending on whenever the emergency use authorization is terminated. So I wouldn't expect it to be $41.52 for all of next year. It'll go down at some point. We just don't know when or what that amount will be, but it'll probably be similar to that 31. They also created a new APC for home administration of the COVID-19 vaccine, and that's going to have a payment of $36.85. And that one should not change regardless of what happens to the emergency use authorization. So confusing enough, it will either be 31 or 41, but not for the whole time, 36 if you give it in the home. All right, let's stay with COVID for a little bit because it's so much fun. They're going to continue to pay for the monoclonal antibody pre-exposure prophylaxis. So those are the drugs that are given when someone tests positive for COVID and is at high risk of complications, trying to prevent that. That's going to continue to be paid under the Part B vaccine benefit, even after the emergency use authorization is terminated, as along with the caveat that those products have to remain authorized by the FDA, which I think makes sense. The FDA doesn't approve them and authorize them, there won't be any payment for them. More to come on the exact payment of those. We are all over the place. Endoscopic submucosal dissection. So that is, during an endoscopy or a colonoscopy, elevating and destroying underneath the mucosa. That is getting a decent reimbursement update. The status indicator is not changing. So it's still going to be a comprehensive APC, but it is going to be reimbursed a little bit better. Here's actually one of the few decreases, which that usually doesn't happen. Usually there's more decreases than increases, but this procedure for the external monitoring of the heart rate for 2 days up to 7 days actually went down a little bit in reimbursement. The iBox that I doubt very many of you are doing, that's for the concussion protocol. That is simply a status indicator change. And that's, again, it was a Q1, which meant that if you came into the emergency room and got an ER visit and then had the iBox done, it was bundled in and didn't get separate reimbursement. So for next year, this will actually get separate reimbursement, even if it's done with another service on the same day. I think that was keeping a lot of people from using it before. It really didn't get paid for a lot of times. All right, another new technology one, the IV stem that's put behind the ear actually and is for treatment of irritable bowel syndrome. That one's getting a good reimbursement boost. The in-space subacromial tissue spacer, which is usually used for massive rotator cuff repairs that just aren't going to be repaired any other way. They created this new code to make sure that everybody understands all of the things that are included in that. So it not only includes the spacer insertion, it's also debridement, decompression, acromioplasty, and tenodesis of the biceps when performed. It got a very nice little boost, but they wanted to clarify that it includes all those things and increase the reimbursement. Medical physics dose, this is the facility charge when there is a review for the amount of radiation that patients are getting. That's increasing nicely. And the pathology service, the FISH study that's used to detect bladder cancer, that one's actually going down by quite a bit. The breast localization device with mammographic guidance is basically being moved into the same APC, or excuse me, it's being moved up and out of the APC where everything else is right now. So it's going to get quite a boost. The other ones that use the ultrasound guidance and the fluoroscopy guidance are going to continue to stay in the lower paying APC. Another new technology, the cryotherapy of the breast tumors. This one is, for this year, it's not paid right now. It's an excluded procedure. Medicare's determined that this should be payable for Medicare beneficiaries, and so it will be reimbursable next year at a decent rate there. So again, if that's one you've been considering and weren't going to do it until it became payable, it will be for next year. The total ankle replacement is being reassigned APCs, and it got a very nice jump too. They realized they were underpaying for the implant on that one. Coronary sinus reduction device, that's another, that actually creates a bit of a lesion to allow it increases pressure in the coronary sinus, so it helps to redistribute. It's in an experimental right now, but it will be allowed to be paid if you are one of the facilities that actually is looking at doing that. Dental services. This is kind of a big change. When you have a Medicare patient who requires dental services under monitored anesthesia in an operating room, there's a new code for that now, and it is going to be reimbursed. But this second bullet here is kind of important. You can only use that to bill for services that meet Medicare coverage requirements. And there are not many dental services that Medicare will cover. So I actually see this being used a lot more outside of Medicare, like Medicaid and stuff, the kiddos that need to be sedated, that can't handle the dental services in the operating room. But that's the way this is right now. So they did keep code 41899 intact. It doesn't get nearly as much payment. It gets $200, but it should still be used if you have dental services done in your hospital that don't meet the criteria for G0330, which is, basically requiring the anesthesia care and the operating room. This still can, it should only be billed to Medicare when you've got a covered dental service being performed. But that's the difference in those. So this is actually very nice and should hopefully allow payers to start paying hospitals for their operating room time for dental services. Urology services, I'm just kind of listing out for you here. There are 8 different procedures whose reimbursement, again, is almost doubling. So you can see what we've got here. It's basically the repair stuff, although ablation of malignant prostate tissue with the ultrasound is in that group as well. All right, payment for devices. This one should be fairly quick. Again, I kind of just wanted you to have the information out here that we have 8 devices with continuing pass-through status. And again, I tried to give you the product name here so that you kind of know what you're dealing with for these codes. Right now, because these are new technology devices, there is only one device that meets that qualifies for these codes. That could change later, but right now it's one. We have 6 that are expiring. So the Augment, the Remede, the Optimizer, these are no longer going to have pass-through status in 2023, which means the cost of the devices will be bundled into the procedure. And then we have, depending on how you count, 3 or 4 new devices with pass-through status. So basically there's 3 new ones, but there is a 4th that just became eligible for pass-through status in October. I put it on here because we hadn't talked about it before. It's pretty new. So we've got the Ureterol ureteroscope. We have the Evoke SCS system. So that's for chronic intractable pain in either the trunk or the limbs. Usually it's done during, for failed back surgery syndrome or just intractable back or leg pain. We have the Vivistim system. So that is a generator that actually stimulates the vagus nerve. It's supposed to reduce the motor deficits in the arm, usually for patients following chronic ischemic stroke patients. So that's kind of interesting technology. And then we have the, I'm not exactly sure how they say this one, but I'm going to say a My01 device. And that is for continuous monitoring for patients who are at risk of compartment syndrome. That's the one that has been in effect since October, but we hadn't talked about it before. So all of those are going to get separate pass-through payment based upon cost, modified by cost to charge ratio information. All right, CMS kind of, for the last couple of years, they've been emphasizing this, so I just wanted to keep this in my presentation, which is that CMS hasn't produced a list of specific device to procedure and procedure to device edits since 2014. They still expect you to charge for your devices separately and to put a code and a charge on the account when you have a device intensive procedure, but any device will bypass the edit that's on their list. So in VitalWare itself, if you're a VitalWare client, we have a list of the expected devices, and we also identify for you which procedures are device intensive. But CMS wanted to emphasize that, I guess, that they expect that hospitals know how to code for these things. And they just want something on there. It's a little strange, but whatever. They also emphasize that C-1889 doesn't, it can be used with devices that are outside of procedures with device intensive status. So they're actually encouraging C-1889 on all devices that don't have their own HCPCS code. All right, drugs. This one's going to be a little bit fun because there were some fairly big changes here. So we'll start with the easy stuff. The packaging threshold is going up from $135 up to $135. It was $130 last year. So that just means when CMS goes to make a decision about whether or not to package the reimbursement into the procedure, they're looking for the cost of the drug to exceed $135 per day. And they're using the most current information they have, which is the second quarter 2022 data in this case. But that is how they decide whether or not they're going to package something. It's got to exceed that $135 cost per day. They made a little bit of a change to biosimilars. So those are the drugs that are made from living organisms. They're made slightly differently than the original drug. It has to be as safe as and work as well as and work in the same way as its parent drug or reference drug. Of course, it has to be approved by the FDA. But typically, the biosimilars cost less than the parent drug or reference drug. And so kind of in order to rectify that cost difference, the biosimilars that have a cost that is less than or equal to the reference drug, they're going to be reimbursed at ASP plus 8%, whereas the regular drugs have been since the beginning of the OPPS reimbursed at ASP plus 6%. So you're going to get 2% more for 5 years. And that was mandated in the Inflation Reduction Act of 2022. They're trying to support production of biosimilars to help drive down drug costs. And we'll see what that does or doesn't do, but that is the intent of it. It actually began October 1st. So if you use any of those biosimilars, you're just going to get a little bit of a boost in the ASP. So just kind of hopefully encouraging folks to use those cheaper biosimilars. All right, here's the big one that I think a lot of you are probably aware of already. Medicare lost this summer. The decision, the case went to the Supreme Court and CMS lost. So CMS was basically asking to be able to continue paying for 340B drugs at ASP minus 20, oh shoot, is it 23%? I guess I should have put that out there. 23%, I believe, 22%. So they lost that, and that has been happening since 2018. So since 2018, they've been paying for these 340B drugs at a much lower rate. They've now been told they can't do that. And so any drugs acquired under the 340B program are going to be the same payment methodology as all other drugs, which is ASP plus 6%. However, this decision, the 340B drug decision that was made way back in 2018 was a budget neutral decision. So what I mean by that is the money that was not being paid in drugs was basically pumped into the OPPS in other ways by increasing payment for all other services. CMS now has to find a way to undo that in a budget neutral manner. They're not authorized by Congress to add money into the program. So there's going to be a separate final rule published to address necessary adjustments related to this alternate payment methodology for the past several years. They're going to release it sometime in 2023, but they're trying to figure out right now how they're going to undo what they've done, because basically they have to take money away to keep it budget neutral, unless Congress was to somehow act and say this was exempt, which would be nice if they did, but I don't see that happening. Okay, so the upshot for everybody out there is if you have drugs that are purchased under the 340B program, you still have to use modifiers to tell CMS which drugs are being purchased under that program. So darn it, this isn't going away. You're going to use the modifier JG if you're an OPPS facility. And if you're a sole community hospital, children's hospital, or a exempt cancer hospital, you're going to use modifier TB, just like you kind of always have been. The modifier JG is not going to cause any payment reduction. It's informational only, but it does have to be on there. All right, kind of staying in drugs. I never know if these are really drugs or supplies, or they're kind of a combination of both, honestly. So the synthetic skin substitute products. Right now, you would code that using a C-1849. That is causing problems because physicians can't use C codes. And so CMS is deleting this C code. Any synthetic skin substitute is going to get its own product-specific A code, and it's going to be automatically assigned to the high-cost skin substitute application group. So right now, this is what we have for the synthetics. I'm sure there's going to be more to come on that, but that's what we've got so far. Probably there's going to be a lot of questions about this one too. We have a new JZ modifier, and you can see the description of it there is 0 drug amount discarded, not administered. So this one's going to be fun for everybody, and you do have some time on it. You've got about 9 months, well, a little more than that, to figure it out. But basically, any single-use vial is going to have a modifier. So if you discard some of your single-use vial, so let's say it's a 100 milligram vial, you give 90 milligrams to the patient, you throw away 10 milligrams. In that case, you would build a 90 milligrams on a single line without a modifier. You'd build a 10 milligrams on a separate line with a JW modifier to show that you wasted 10 and go on with your life. If you have that same 100 milligram vial and you give all 100 milligrams to the patient, you're now going to have to use a JZ modifier to tell Medicare that you didn't waste any of it. So that modifier is effective on January 1st. It will have voluntary usage for now. It can be used by the RACs and other auditors on July 1st, but CMS isn't going to implement any kind of claim edits looking for this until October 1st, 2023. So I'm going to imagine this is going to be a little bit of a mess for folks. Hopefully we've gotten really good at the JW modifier, and that will make this a little bit easier. But I can't even, I keep thinking through this, and I'm not sure how we're going to make this work, because the clinicians that know whether or not there was wastage are, I think, pretty obviously not the ones doing the billing. So this is going to be a little bit of a trick as far as who's going to apply these modifiers and how we're going to get them on there accurately. They just keep adding things. this is the kind of stuff, again, that makes me go, okay, are they just sitting around going, how do we make this harder? It's too easy. We got to make it harder. The other thing is that there's going to be more to come on this, because right now, so if anyone has any questions on this, I probably won't be able to help you at this point. CMS has said they're going to be publishing instructions on this and how to do this. But personally, I think right now they don't even have this figured out. But there will be instructions coming. And so we'll make sure that we get that out to all of our VitalWare users via Vital Alert and maybe a Q&A document. We'll help you guys through it as much as we can. All right, we're going to buzz through the partial hospitalization pretty quickly. CMS is using their equitable adjustment authority just to keep the payment up on these, because the payment continues, the cost of this reported to them by hospitals and community mental health centers continues to decline. They can't figure that out. I can't figure that out. So they're going to just make sure that they, in order to support these programs, they keep the reimbursement at what it is right now. Okay. The inpatient only list, that lovely list that was going to disappear last year, and then they reversed themselves and it came back. I don't think it's going to go away for a bit. However, some of the codes that were on it are going to go away. So these are the codes that have been removed from the inpatient only list for 2023. I gave you the status indicator that's going to have for next year and the national reimbursement that it's going to have for next year. And see, we're kind of all in the same, basically they're mostly facial surgeries. We do have lumbar arthrodesis and an intraoperative cholecystoscopy that came off of the inpatient only list because they can be done with outpatient procedures. And then, as always, we have a few codes added. We kind of already talked about the hernia repairs that were being added to the inpatient only. We also have implantation of mesh or prosthesis for delayed closure of defects. So when you insert mesh or a prosthesis during your hernia repair, that's included in all the new hernia codes. This would be for mesh or prosthesis that's done for other indications. And then we also have the artificial disc insertion via an anterior approach or through the front of a patient's body into the lower back. That's also going to be an inpatient only procedure for next year. Told you they did a lot this year. I just wanted to keep this in here. This is from last year's presentation, but this is another great reminder. Again, CMS is emphasizing it, that just because something is removed from the inpatient only list, it doesn't mean it can only be done outpatient. That's really, really important. Let the physician use his judgment as to whether or not it needs to be inpatient or outpatient. And also, if it is on the inpatient only list, don't even think about it. It doesn't matter if the patient is only there overnight. If it's on the inpatient only list, that patient needs to be made an inpatient. They're trying to make this a little bit easier, so take the rare gift from CMS and make it easier on yourself. All right, non-recurring policy changes, and here we go a lot. Remote mental health services, and this is important, following the end of the public health emergency. So right now, under some exceptions, during the COVID PHE, you can provide remote mental health services. They're going to allow that to continue with some caveats, of course. The patient has to be at home. The provider has to be licensed by the state that they're in. And there has to be an initial in-person visit within 6 months of starting the remote mental health services. And then they need to have a subsequent visit basically every year. There are a couple of exceptions here because again, we wouldn't want to make this too easy. So the requirement for the in-person visit is only going to start on the 152nd day following the end of the PHE. So everybody get out your calendars and click when that PHE is up. There is a slight exception for that. And there's also an exception for patients if the physician documents that coming in would cause harm to the patient, then that in-person visit is not going to be required, but make sure that's very well documented, okay? Audio-only communication is acceptable, but it has to be on the part of the patient. The patient has to not be able to get video. The hospital still has to have the capability to provide audio and video services. But if for some reason the patient can't get that video, you can provide these audio only. Okay, so here's some new codes for these and how they're going to be reimbursed. So you can see it's the first 30 minutes, first hour basically, and then each additional 15 minutes, which is a bundled service there. So make sure at least 15 minutes of service has to be provided before you can report any of these. But if you do any of that remote mental health stuff, there's some new codes for you. All right, staying with our remote theme, cardiac and pulmonary rehab services are on the list of Medicare telehealth services. So that's going to allow you to provide the remote rehabilitation services through the end of 2023. Okay. CMS didn't have the authority to make these permanent exceptions because this was all done under COVID flexibilities. But for right now, you'll still be able to provide these through the end of 2023. And your supervising practitioner can supervise them via two-way audio-video communication also through the end of 2023. We'll see if something else changes on the next final rule for that, but right now that's what we've got. There's a little bit of change to supervision requirements, which is basically going to allow non-physician qualified health professionals to supervise outpatient diagnostic services as long as they're practicing under their state's law and within their approved scope of practice. And again, we're going to allow them to supervise via remote audio-video communication, at least through the end of the year, whichever year the COVID-19 public health emergency ends in. So at this point, that's probably going to be 2023, but we'll see. Okay, we kind of talked about some of those SaaS codes, the software as a service code. So those are the services that are not actually usually taking an existing study. It's actually the artificial intelligence interpretation of a study. And so CMS is going to allow those to be separately reimbursed for next year. Right now, they're add-on services and there is no reimbursement. All right, status indicator description changes. We talked about C9399. Because of this change, they're just revising the definition of status indicator A, and they're including the fact that it's unclassified drugs and biologicals. Not a huge change there, but these are, the descriptions are changing, not really the intent. Okay, and we just moved the hepatitis B vaccines from status indicator F to L. No change. It's just going to make sure that your hepatitis B vaccines are never subject to deductible and coinsurance, so the patient won't have to pay anything for those hepatitis B vaccines. The whole reason for that. Clinic visits are not really changing. We've been trying to get this one changed for a while. It's not changing. So if an outpatient clinic visit is provided at an off-campus physician-based clinic, it's going to be subject to a reimbursement reduction. It's basically reimbursed at 40% of the OPPS reimbursement. So basically it's reimbursed at $48.34 for next year. There is an exception, which is going to be important if you're a rural sole community hospital. This is not going to apply to you. You still have to assign the modifier to let CMS know that the service is being provided in a provider-based clinic, but you're going to be reimbursed the full outpatient prospective payment system of $120. Oh, we're just changing gears so fast. I apologize for this fast pace, guys. The problem is when we schedule these, we don't have the CMS hasn't released anything. And so we kind of guess at an hour, and this one probably could have been more. But we just didn't know how much CMS was going to release until we actually got there 2 weeks ago. All right, so prior authorization. These are the services that currently require prior authorization. Again, I wanted you to have this all in one place. You probably already know this, but the reason that's there is because we now have a new service requiring prior authorization as of July 1st. So again, you have a little bit of time on this, but it's going to be those facet joint injections described by any one of these codes. These are now going to have to go through the prior authorization service when you are anticipating one of these CPT codes be used on a patient. So we're continuing to expand that program. Lovely. All right, and then there's not going to be a lot, again, to say about the outpatient quality reporting program. This is becoming more and more and more important, and I wouldn't be surprised if CMS starts upping penalties or doing other things to make folks compliant with this. So we have these measures that are going to be required for 2023 reporting. In fact, all of these have been there before, except we've got this cataract one. That's voluntary still right now. They're going to require reporting on that in 2025. And the dreaded OAS CAPS, which is the patient surveys that have to go out. This has to be done via, it can't be done by the hospital, right? You have to contract with a vendor to do that, and they have to be approved to do that. That is technically a requirement for this year, but it is still voluntary. Next year, you're going to have to report on that one, and that's going to be a biggie. I think a lot of people aren't really doing this one right now. We also have a new electronic quality measure, which means you don't have to do anything about it, really. CMS extracts this via claims data. That's also voluntary right now. I don't know how you make it voluntary when you're not doing it, but that's going to be required for 2024 as well. And then we have a new type, I guess I'll call it, of facility, a rural emergency hospital. There's only certain hospitals that would be able to convert to this, but I wanted to throw this out there in case we have any critical access hospitals or rural hospitals that are considering applying for this status, just so you can kind of see what this is going to be. So you have to be a critical access or a rural hospital. You can't have more than 50 beds. You have to provide emergency department and observation services. You have to have a staffed ER with one of those, with either a physician or one of those approved qualified health providers. You don't provide inpatient services. You have to have a transfer agreement in place with a level 1 or 2 trauma center. And you excuse me, you have to meet the conditions of participation for an emergency room. Now, I'm going to caveat that does not provide inpatient services. You can provide post-hospital extended care services, like a SNF, but you can't provide regular inpatient services. So why would you do this? What's the upside, downside? Just again, in case you've got somebody that is considering enrolling in this, if you're considering changing your hospital, you're going to get the Outpatient Prospective Payment Service plus 5% for any covered service. The beneficiary is not going to have to pay any additional 5%. Medicare is going to pick up the difference there. Items currently paid at fee schedule are going to continue to be paid at fee schedule. So things like your ambulance, your therapy, mammograms, labs, that's you'll get that fee schedule amount. You're also going to get an additional monthly facility payment that's going to be calculated every year based on the magic that CMS does. For 2023, it's going to be almost $273,000 per month for each hospital that elects this particular designation as a rural emergency hospital. And if you provide any service in an off-campus provider-based department, you're not going to have any payment reduction for that. So again, I don't know if we have anyone in the boat considering this, or maybe that has already applied for this, but this may be good information to take back to your financial folks and just to give them a brief, what's good, what's bad, if you're trying to make the decision as to whether to apply for this particular designation. Whew, that was it. There is a lot of information there. Again, we probably don't have time for any questions at this point, but if you have any, please make sure and type in the, am I going to say that? It's in the Q&A, right? Marie, is where you want that?
Yes, in the Q&A panel. Yep, and we do have quite a few questions. So like we said, we'll make sure to get all of those answered in a document and post them to our website. And yeah, thank you everyone for joining us today. We know we covered a lot, but we hope you found it helpful. We will send out those CEU certificates by end of day tomorrow. If you don't receive them for some reason, you can just email us. I would recommend checking your spam. Sometimes they go there, or sometimes they get blocked by your server. So just reach out if you don't receive them. And the slides are also posted now on our website. There will also be a link sent out with the CEUs by tomorrow as well. And I think last couple of things, we do have a few more upcoming webinars for the rest of the year. I think there are 5 more, if I'm correct. So just check out our website and register for those. And there is a brief survey after the webinar ends. If you want to take a couple minutes to fill that out, it helps us for future webinars. And I think that's all. Thank you everyone for joining, and we hope you have a great rest of your day.
Thank you.